Welcome to this episode of Orthodontics in Interview. It's my absolute pleasure to have here Dr. Enzo Pasciuti. Thank you so much for joining me.
Thank you. Thank you. It's a pleasure for me to be here. Really, really a pleasure.
So, I had the pleasure of meeting Enzo in Brussels at this year's uh, European Aligner Society Congress. Now, we hit it off at the speakers meeting, and Enzo has some exceptional insights into not only the world of aligner orthodontics, but overall in terms of how we progress our clinical practice as an educator. Now, I stopped him from talking too much to me that evening because I really wanted to do this interview. So thank you again, Enzo, for joining me. I'll get quickly through the introduction and then I'm going to ask you the first set of questions. So Enzo Pasciuti, he is based over in northern Italy. He did his dentistry from Milan in 2004, the same university for his specialism in orthodontics. Now, was a contract professor until 2012. He's based over in northern Italy in Tridate and has been there since 2014 in private practice. Treated over 3,000 patients. He has a number of certifications. He is a Italian Board of Orthodontic Aligner member, European Board of Orthodontists, EBO, very prestigious. He's achieved the European Board of Aligner Orthodontics, the EBAO. In terms of teaching, Enzo's gone in two different directions, and you may disagree with that term, but he teaches the MBT system and foundations and philosophy, as well as teaching on aligners. He is a key opinion leader for Ormco with Spark Aligners and has also spoken for dental monitoring. He's spoken in a number of international conferences. He has courses that are always booked out. It's great to have you here to really get into your mind. Enzo, the first thing I want to ask you is picking up our conversation from Brussels. Your rates of refinement are lower than the average. First of all, how did you work that out? And what do you think you do to achieve these lower rates of refinement for your aligner cases?
Okay. To answer this question, I would like to tell you the story and what happened when I start to be a big speaker and I start to take lecture all around the world. Because I opened my orthodontic office in 2014, close to Milan. And for the first 4 or 5 years, I work only by myself. Okay, me and a couple of assistants and a couple of secretaries. Then when I start to do lecture and more courses about aligner all around the Europe, outside also Europe, there was a moment in which I realized that there is no way to treat this big amount of patient only by myself. And so free orthodontists start to work with me. But they didn't have time to check what they do. They usually take scan, put some attachment, do some IPR, and then make some scan for the refinement. In 2020, at the time I was working with Invisalign, as everyone was, I received a call from Align Technology, and they say, Enzo, what happened? And I say, hey, what happened? And they say, because they have the statistic of every one of us. And they say to me, Enzo, we realize that the amount of refinement is increased a lot in your office. From 2014 to 2018, usually you have that 50% of the cases you do in two shots. So the first set of aligner and then one refinement. The 25% is with two refinement. Then there are many complex cases which you need 3 or 4 more refinement. But now in the last 1 year and a half, you increase a lot the number of refinement. What happened? You forgot everything about biomechanics. And that was the moment in which I realized that I had a problem. And the problem was that I thought that the orthodontist that worked with me could make the refinement for me. Okay? Or if you want to see it in a different way, in the moment in which they took the scan, send everything to Invisalign, at the time, I receive a clean check. And I start to design the refinement on the clean check. But remember, my friend, that on CleanCheck or whatever, any software, doesn't matter how the teeth occludes. The cut designer will always move the teeth. And I learned this thing when one of my patients that I used for the European Board of Orthodontics was treated with braces, was a perfect occlusion. They judged that it was a perfect occlusion. He lost the retainer after, 3-4 years, He come back to my clinics and say, I need to retainer, new retainer. And I say to my assistant, okay, take a scan and order a Vivera. At the time I used the Vivera, but she made a mistake. And instead to arrive the Rivera, I receive a clean check. And can you imagine how many aligner, a CAD designer in the other part of this world think that we need to improve the occlusion of this guy 16 aligner, and the occlusion was perfect. So these two facts allow me to oblige me to think about and say, how is possible? The case from a clinical point of view is perfect, then you send the file and they want to continue to move the teeth. And a lot of time they make it worse, but that's another problem. Okay. And that was the moment in which I realized that the big difference between my approach to the finishing in straight wire and in aligner was that I judge my work with the braces clinically on the dental chair, in the liner virtually on a computer, and it makes no sense. So for that moment, I say to my orthodontist, you can put attachment, do whatever you want, but I want to be the only one that see the case the day in which they finish the first set of aligner and we have to start the refinement. Okay. And what has changed was the approach to the refinement, because today what I do is, okay, I, I set my goal, and so I achieve all the goals. So we are really, it is really a finishing phase. So I achieved the class one, the middle and the center, the guidance are okay. So we have to do the refinement of the case. First of all, I take OPG as I do on straight wire. Second things, I don't check the scan. I put my retractor and I analyze the occlusion clinically with the patient to see how the occlusion how is work. And I ask to myself, okay, if this patient has the braces, what do you want to do? Maybe I want to extrude 0.5 the canine. Maybe this I don't know, premolar need a little of distal crown tip, maybe the torque, and I take notes. Then I send everything to the CAD design company. Today work as you told on Spark. I send everything to Spark. I didn't say nothing to them. I want always to see what they want to do. A lot of time they move the teeth for nothing. Then when I receive the simulation, I lock everything. I lock. I put them, not move them, so they come back to the original position, and I do the adjustment. Then I will do at the dental chair if I have the braces. Because, and this is my philosophy, I believe that the goal of a good orthodontist is not to achieve the perfect occlusion, because it's the function that give you the perfect occlusion. Our goal is to move the teeth to allow that the function create the perfect occlusion. And so it means that a lot of time you don't need to move the teeth. You can see my cases in my courses on Congress. I feel I have a really high level of finishing. Okay, so that's to answer to you why I have less refinement, because in refinement I do what I really need to allow the function to give me the perfect occlusion. And that's the first part of the question. And the second is that one of the reasons why, okay, I can say to you that the predictability that I have is really higher in relation to the average value in the world. And I know perfectly in the moment in which I discovered the insight from dental monitoring, the predictability of my cases is really high in relation to the other. And the reason is related to, and seems to be stupid, but for me it's like this, is the number of attachments. I have some cases with 28 attachments. So I strongly believe that the attachment really, if you know how to use, if you know how to plan, really help you to be really, really more predictable. In fact, if I open my insight, they say to me that my movements are really, really more predictable than the other, especially in the frontal teeth, especially on the upper lateral incisors. Why? Because I always use a rectangular horizontal gingival bevel attachment on incisors if I don't have nothing to do. Otherwise, I put a sash or whatever. Okay, but I use a lot of attachment. That could be one of the reasons. Another reason why we reduce the number of refinement is the dental monitoring, because even if I'm a speaker of dental monitoring, if you ask to me, do you know how to use the platform? No. I have my dental monitor coordinator that do it for me. Okay, I have two girls here and one in Milan that do everything for me. Okay, I mean check everything, but the idea that you can check loosening the fitting in one shot when it's a little small misfitting before it becomes a huge amount of fitting, and stop the treatment. Stop the treatment means, hey, don't change the aligner. Keep the same aligner, use your chewies, and until the tooth will not track, you cannot move on you cannot jump on the next aligner. It's something that allow me to increase the predictability. Okay, and so what does it mean? It means that in most of my cases, when I arrive at the end of the first set of aligner, it's really done. I mean, it's done. So the patient is in class one, the T4 aligned, everything is okay, and I have to do a refinement. Okay, imagine I do a lot of class two correction. Okay, in class two patient, you can do, I don't know, distalization. Okay, and in that case, the number of aligner is the number that you need to distalize every tooth from class one to class one. But I love to use, for example, the interarch mechanics that I learned from McLaughlin from the braces. Braces in the upper lower, class 2 elastic, stainless steel archward, it goes in class 1. I love to use the interarch mechanics, someone called the virtual jump, in adolescents, in adults. I use a lot. And what's usually explained in the courses is that the number of aligner that you have in the first set is not related to the amount of class 2 that you want to correct with interarch mechanics. It's related to the amount of the number of aligner that you need to, I don't know, derotated, flatter curve speed, and blah, blah. So a lot of time, when I arrive at the end of the first set of aligner, everything is perfect except the class 2 because it's not fully expressed, fully corrected. So most of my colleagues, what they do, okay, the patient finished the liner, order a refinement. I don't do like this. I always have at minimum 6 passive aligner. Okay, in every package of the first set of aligner, I was, I don't know, 30 aligner. I received 36, 30 active and 6 passive. And I use the passive aligner to allow the patient to correct 1 millimeter per month the class 2. And when the patient finishes the 36 aligner, if it's done, so I mean, if we are in class 1, it's time to do the refinement. Otherwise, I don't take a scan. I reorder aligner from number 31 to number 36. And I give the patient other 6 weeks to use elastics. And if I need more 6 or other 6, because when I want to jump on a second set of aligner, the class correction has to be done for me. Otherwise, it's not a refinement. It's a second set of aligner. Okay? And that's for normal cases. When I approach complex cases, it's a different story. What is a complex case for me? A complex case is, or when you have the malocclusion that is expressed in all the three dimensions, so a strong debite class 2 with a crossbite, something like that, or impacted canine, something like that. Okay, there are some complex cases in which I want to, and that's another thing on my philosophy. The problem of the CAD designer, generally from a liner, is that they want to achieve everything in one shot. So they want to achieve in one set of aligner everything. It's working in normal cases. But if you have complex cases, sometimes it's better to say, okay, now before I coordinate transversally the arches, at the same time I do the disimpaction of the canine. Then the canine is palatal, I order the second set of aligner, I move it backally, try to adding extra buccal torque, at the same time we do maybe the class 2 correction. So what I want to explain to you is that when the case is complex, sometimes I have more set of aligner, but only because in every single set, set of aligner, I decide a goal of a couple of goals. I arrive there, and then I move to the second set and the second goal. Okay, and so in that case, it's probably sometimes I need 3, 4 set of aligner, and then I do the refinement. Okay.
Excellent. So, Enzo, there's just so much there. I just want to, can I summarize this? Because I think this is going to be really valuable for the listeners. So, in terms of reducing your refinement rates, one of your key components to that process is ensuring that you are clinically seeing the patient to plan the refinement, not from the digital models. You will ensure you use more attachments rather than less. When it comes to looking at your cases, you're using dental monitoring to keep an eye. But crucially, I think that you clinically see them when it comes to doing the refinement prescription. And finally, the fourth thing, really interesting, your sagittal correction, you'll use a class 2 elastics. It's not the number for aligners. You will make passive aligners 6 for the case so they can get the sagittal correction and order more if it's necessary. And finally, your complex cases, you divide the stages. You're not trying to do it all in one go. You're trying to build around the complexity of the case and then assemble them each one by one. That's really amazing. That I think in itself should end the podcast. But I need to ask you more questions, Enzo, because I feel like there's more that we can get from you. But that's
I forgot to
really,
say, I
yes,
forgot
please.
to say something, sorry, and that's really important. A lot of colleagues think that when a liner is on the boxes, you say you read passive aligner is passive, but it's not the truth. So a passive aligner is really a passive aligner if you already express the 100% of the movement, but it's not the truth. Okay, we know which is our predictability. So that's the reason why I use a lot the passive aligner. That's the reason why it doesn't matter when I spoke with Invisalign and now I spoke with Spark, I always say to everyone that they never order a Spark 20, Invisalign Lite, Spark 35. I use only open advanced cases for Spark or full cases for Invisalign because I want to have all the active and passive aligner that I need to finish the case. Because then there is another thing, probably is not in the topic of today, but if you give me 2 minutes, I want to put something, and is the stabilization. So there is a paper. I don't. I you know I'm not a scientific man. I'm a clinical man. I read articles, but I know how to judge them. But there is a paper of couple of papers that say that we have more relapse with aligner than braces. And I asked to myself, why? And it's something that happened in my clinics. I have more relapse with with aligner and braces. And I asked to myself, why? Because usually when I have a problem, I stop everything and I ask to myself, why? And until I don't find the answer, I don't move from my desk. Okay. And then I realized that the movement that tend to relapse more with aligner are the vertical, so intrusion, extrusion, and the rotation. And the answer that I gave to myself was easy. In straight wire technique, so with the braces, when we finish to control the rotation, at the end of the leveling phase, so when you put a stainless steel arch wire, the rotation is already correct. Then maybe you do class 2 correction, 6 months, 4 months of refinement, and then you remove everything. And so what does it mean? That for at least 6, 8 months, nothing happened on the tooth that was derotated. And so you allow the reorganization of the transeptal fibers. And in the literature, we can find paper in 1980 something that say that the transeptal fiber required 232 days to be reorganized. I don't know if who found out this number, 232 days, but more or less it's between 7 and 9 months. Okay, with the aligners, a lot of time you complete the rotation with the last aligner, and then if you jump from 22 hour per day aligner to okay now put only during the night, you have relapse. Okay, so what does it mean? In every one of my cases I create, okay, with the braces I use align, leveling, working face, finishing, and retention. With with the liner I have a new phase: aligner, leveling, mechanics, refinement, and then I do a stabilization phase. And my stabilization phase lasts 9 months. So what does it mean? That the patient for the next 10 months, I'm satisfied, you are satisfied, you are the patient. Okay, both of us are really satisfied. Before jumping on the retention, 10 hours per day, so during the night, I want to that we stabilize the teeth. So for the next 10 months, you continue to put the same passive aligner. Use each one per week. Don't worry about that because I pay the company. So I has to have 24 passive aligner, all of them the same, but the patient is used to change every week. And so they have to change every week. And they decrease from 20 hours per day. For the first 3 months, they continue to wear 22 hours per day, and then they reduce 1 hour per week. And it goes from 22 to 10 hours from the 4th month to number 6. Okay. And then they use the last aligner for 3 months because there is an idea and a concept. I don't know if I can explain perfectly in English, the fatigue of the aligner. So when you continue to wear the same aligner, you destroy it. And the fatigue is the thing that allows the settling, the spontaneous natural settling under the function. And so when the patient switch the liner in the next 9 months, in the first 6 months, every week, so this is the reason why I ordered 24 liner, the first 12 full time, and then decrease 1 hour per week. And then the last one, the number 24, they have to wear 10 hours per day for the next 3 months. Destroy the posterior teeth, the posterior part of the liner, the fatigue. You remove, you put, remove, you put, okay? And allow to have the setting. And in only that moment, I take the new scan and we do the retainer. And in the moment that we start to develop the protocol and use this protocol was 5 6 years ago. I have to say that today I've reduced the amount of relapse. Sorry, I don't have the word. I reduced the amount of relapse. Okay, probably because I allow, from the biological point of view, the reorganization of the transeptal fiber or the teeth. Okay, and that I explained this thing because it's related to the passive aligner, and so if people could take a message for me is it's like is use only advanced cases. No, because we need to have all the aligner that we need. It's like if you say to me, Enzo, you have to treat this case with MBT, but you can use only two arch wires, 016 and the 19 and 19 by 25 19, but not stainless steel. I cannot achieve nothing. Okay, and that's the reason. Okay, sorry if I decide to move.
That's great. That's really interesting because I suppose the phases of fixed appliances are so well established across multiple authors. Actually, we've never really delved into the stages of aligners. If anything, is they've been described as being a single stage where you can do all things in one go. And what I'm getting from you, Enzo, is actually we should divide up these stages, especially for complex movements, but also give credence to our established science in terms of relapse and periodontal reorganization, and not think that the appliance negates that. I like the fact that you focused on retention because it can be a trend just to get to the end of the case, but actually what happens after that. And I'm really happy that you've described that in the detail that you have. I'm going to look at predictability. You've mentioned it a few times. Now, predictability in terms of research, predictability in terms of your clinical practice. So there's loads of different types of tables on predictability. We published ours in seminars earlier this year, which looked at systematic reviews, around 15, and we had our table curated. And I'm really interested to know, Enzo, one, do you think that follows your predictability, what you see happening in your clinical practice? And what do you think is happening in your hands, which is different from what's taken place in the research? So the table essentially shows the most predictable movements are expansion, mainly tipping, and distalization. Again, the research was mainly looking at dental landmarks, not skeletal. So it could be tipping or bodily movements. The least predictable movements were torque, root tip, extrusion, and interesting, the least predictable was intrusion. Do you find yourself agreeing with this, or do you think that actually this is not correct?
Okay, I can say that generally I agree with this table. Okay, and this is one table that I use a lot in my courses. Um, when we speak about the intrusion, I have to say that I was invited everywhere for my deep bite protocol about a liner many years ago. And because I know how to open the bite, flatten the curved spit, and in most of the cases, we are speaking about hypodivergent patients, so I cannot believe that I'm able with a piece of plastic to extrude the premolar. So probably I'm flatter the curved spit more intrude the anterior. So um, I probably not totally agree with the intrusion if we speak about relative intrusion. So if we speak about pure intrusion, is probably the most unpredictable movement with a liner for sure. So we know that the vertical are the most unpredictable movement, and I totally agree. Regarding the cases, we can fix the bite because in most of the cases we looking to have a relative intrusion. So it means some proclination, changing the inclination of the tooth, move the roots back, and blah blah blah. Regarding also the torque, I know that is not predictable, okay, but it's always related to uh, how you plan the cases. So what I discovered, I treated more than 3,800 now cases with a liner. Then I all of the braces, interceptive, and blah blah blah. Anyway, but with aligners, another rule that I found from my clinical experience, and I already more or less told to you, is that the goal of the car designer is always to achieve everything in one shot. What I learned is that if you want really to express the torque, the teeth have to be already aligned. And also for the intrusion, if you want to shoot the frontal teeth, the teeth have to be already aligned. Okay, and that's the problem. A lot of time you see the cut designer that, I don't know, want to do give extra or palatal torque during the retraction, but the teeth are not aligned. So I prefer to align the teeth and then move all the same like a single unit and add a lot of extra palatal torque. So regarding the torque, for example, I believe that if you before align a yes level, and then control the torque like we do the straight wire with the stainless steel, it could work easy. No, easily, no. Let's say like this: it could be predictable, especially if you play. And this is my new topic: play with the plastic. So today I love Spark, not because it came from Arc or nothing, but because I have two different thickness of plastic, and I have different level of trim line. I was in 2011. I spent 6 months in the States, in California, and I had to find a reason to go to Las Vegas for my mom, because, and so I say, Mom, I go to Las Vegas because there is a university. And so I wrote an email to Professor Ma, and Professor Ma allowed me to visit that university. And he showed to me a paper, it was 2011, I think, and he was probably the first one that studied the effect of the trim line on the expression of the force on the liner. And if you go on the conclusion, it was amazing because he wrote down, if you use a high straight trim line, maybe 2 3 millimeters above the gingival zenith, you are able to increase the force level and you are able to perform complex movement, and then he saw like torque. And that's exactly the answer. Today is more predictable what I get, because when I want to increase the level of the force, I use a high trim line, and with Spark, for example, I can use a thicker piece of plastic. So I increase the level of the forces. So there is something that's, I made a mistake for years. For example, imagine when a movement was complex, I slow down the amount. I say, okay, to express the torque, maybe 10 aligner are not enough. Okay, slow down the movement. So I reduce by 30%, 40%. Okay. But nothing happened. Why? Because I reduced the level of the force. But if we come back to the profit book and you go on the chart in which they express the amount of the force that you need to express some movement, they say that when you want to move a group of teeth or we want to move the roots, so torque and tip, you have to increase the level of the force. Okay, and so the reason, for example, for the tip and torque, today for me, the predictability is high, but it's related to the level of the force that is related to the trim line level and the piece of plastic and the thickness of the plastic. Then if we jump on expansion and distalization, okay, expansion, I'm totally agree, is really predictable, but why? Because in most of my cases in adults, we start with a crown that has a negative torque on the posterior area, and so it's not expansion, it's uprighting of the crown. So until you have to do something like that, is 100% predictable. Then, if you speak about bodily movement, I think that you can achieve more 1.5 millimeter per side more of expansion if you know how to plan. So with the right trim line, adding a lot of extra the backer root torque and blah, blah, blah. And regarding distalization, I totally agree that distalization is until 2 or 3 millimeter, but that's the only number that's confused me for many years. Because for many years I read the literature and I say, hey, how is possible? People distalize 2 or 3 millimeter. Castro Florio, a big friend of mine, and they say we distalization is not more than 2 or 3 millimeter. And then I open my computer, I open my cases, and I distalize 6 7 millimeter for a full class 2 to one for class 1, only with aligner and elastic. And so I say, yes, I'll distalize them more, more, and more. And I was convinced that I was able to distalize 6 7 millimeter. But then, a moment I analyze my cases and I ask to myself again, but this is really the truth. And what I discovered, and I discovered it because I start to use Spark, and with Spark I start to see the roots. Most of the time, which you see a full class 2 that become a class 1, the real distalization is 2.5 millimeter. The rest is disinclination and derotation, because the position of the apex of the palatal rods is exactly the same place. And so, and that's really important, because for many years I say, how is possible that with a liner we can distalize a full class 2 And before the introduction of the liner, no one was able with the braces. And there is the Professor Benedict Wilmes that I love. I always speak about him, how we need a task to really sterilize. Because the truth is that if you have a really full class 2, in which there is no compensation, in which not the teeth are no misrotated, no misinclined, there is no way. You cannot use a liner to go from class 2 to class 1. But if you go on the literature, usually they say that 83% of class 2 has a misrotation and misinclination of the molars, upper first molar. And that's the reason why with a liner you can easily go in class 1. It's not distalization, you go in class 1. Because there is a quoted derotation, a quoted uprighting, distal tip, let's say like this, and then 2.5 millimeter distalization. And that's the reason why with a liner we can go. Because I strongly believe that the aligner are the best appliance to control three-dimensionally the teeth. Okay? Derotated, uprighting, and distalized. And so I agree that we can distalize 2 or 3 millimeter if we speak about pure distalization. But that's important that have to be explained to the colleagues, because otherwise they say, hey, literature say that we cannot distalize more than 3 millimeter. And then we see cases of many different valves that distalize 6, 7 millimeter. Yes, because it's not pure distalization. I always say in my courses, if you need pure distalization, put the task, bend a slider, distal slider, and go. But we are lucky in orthodontics because most of our cases at the molar, because there is a lot of compensation. That's all. Okay?
That's great. Thank you so much. And I think that that idea that, interesting enough, you say you've got the clinician side and you've got the academic, but actually what I'm hearing you saying is that you agree. And the idea of the vertical movements being the most challenging, the idea that torque is a challenge, but if you apply first principles of force delivery, actually that's changing. And what's very interesting from our table, we did it 3 years ago, 2023. The range of values have increased as more studies have happened. And what that's really showing us is that aligner research and also the product that is produced is changing. And it's starting for us to become more flexible in terms of what the range actually looks like. And there are ways to change them. So I look forward to doing that table again. No time soon. It took too long. But it'd be great to see what you've described there as changing the trim lines and see, does that then change where that fits into the table? I'll be really interested to find that out. You mentioned about dental monitoring. You also mentioned about having 3 orthodontists there. So my first question is dental monitoring better than 3 orthodontists that worked in your clinic?
Okay, another story. You have to know that I was one of the first in Italy that opened an account with dental monitoring. It was 2018. I started to use the first time, failure. 2 cases, and I didn't understand why to use. And expensive, was expensive. No, I stopped to use. Then there was the COVID. And during the COVID 2020, my wife, that's the manage my office, say, hey, Enzo, we cannot see patients, so give to them the dental monitor. And we start to use it again. But they didn't understand the advantages. And so at the end of the COVID, it was expensive, and I stopped to use that. Okay. Why? Because I have the orthodontists that work with me, and I pay them a lot. That's another story. What happened in 2023 or 22? I don't remember. All of them, they were free girl, free doctor, free females. All of them were pregnant in the same periods. Was not my fault. Don't worry. Okay, but all of them were pregnant at the same time, and so we had a big problem because that was a moment in which I traveled all around the world teaching. I have no time to stay in the office, and I asked to my wife how we can fix the problem. Because if you take beginner orthodontists, you need at least 6 months to train them. And my orthodontist, after the pregnancy, they say, we want to come back to work with you. And so in 6 months, you are ready to work for me, and they want to come back. So my second option was, okay, take some expert orthodontists, maybe expert in straight wide, but not with a liner. Maybe they want to join me in my office to learn by me, from me. But how you can say to an expert orthodontist, okay, stop to work in that office, come in my office, but only for the next month, because my orthodontist want to come back. And was no solution for me. And there was a moment in which my wife, that always has the best solution, say to me, okay, now we have to start to use the dental monitoring. And believe from that moment, the free orthodontist never come back. So today, we are in 2026, I'm the only orthodontist in my office for the last 4 years. And I double the number of the cases that I treat per year now. And I use only the dental monitoring. So that was a revolution. But usually you understand something when you really need it. So in 2008, I use only to play as a game. Let's try it. Make no sense. In 2020, there was a COVID I need, but was a short period of time. But then when I had a real problem, because I don't want that my office collapse, okay, let's start to use. I remember the first 2 or 3 months working a lot at the monitoring. Then I trained my off because I changed all the protocols as usual. Then I train my staff, identify two here and then one in Milan, dental monitor coordinator, and then honestly, I stopped to use. I mean, they has to me something, okay, when they need me. But most of the patients are checked by my staff, okay, and they are not orthodontists; they are assistants.
That's great. That's great to see where you stand in that. I'm going to put a statement towards you by Stefano Troiani, a Swiss based orthodontist. Now, he was at the Orthodontic Summer School, which I attended over in Germany. Now, he stated that the best clinicians for aligners as orthodontists still see their patients every 4 to 6 weeks. My question to you is, Stefano is an expert as a clinician. What do you think about that statement? Do you think you can be as good if you're not seeing them clinically and you are using remote monitoring?
I don't want to say something against or to Stefano. What Stefano in Italian is Stefano. What I say is always my experience. And again, everything in my life happened for some strange reason. When I started to use a liner, I started to use strongly the liner was 2014. I see the patient every two aligners, so every month. Then I increase the number of patients. I have no time. And so I start to say, hey, fix the appointment in 2 months. Then the office was full. I have no time and I start to travel. And so I start to say to my assistant secretary, hey, fix every 3 months, but only because I didn't have time to see them. And then I moved to 4 months. And after that, I start to see them every 4 months. And I realized that my predictability was really high. I say there is no way, there is no reason to see them, I don't know, every 6 weeks. So today in my office, we see the patient on demand. So what does it mean? Usually we see the patient every 4 months, or on demand. It means if you have to put the button for attachment, they have to start to use elastic, okay, they will have an appointment. Otherwise, most of them we see every 4 months. Some patients that live outside Europe, we will see every 6 months. And it's work, and my patients are really, really happy. Because I remember when I see the patient every two aligners, for me it's work like a deliverer. So I'm the man that give you two aligner per time. Every time I look at the patient in the mouth, I cannot see nothing because two aligners is nothing. Okay. And so I'm losing my time. They are losing their time. Maybe they wait 20 minutes in the waiting room. They arrive. I give two aligner 1 minute. How are we going? Go, go, go. Okay. I respect a lot the time of the patient. Okay. And that's the reason why we treat a lot of patients in my office, but if you come to visit my office, there is no a lot. So we see between 60, 80 patients per day. So it's not a big amount, a huge amount, sorry. But why? Because we see at least every 4 months. There is no reason to see them earlier. But I know that my cases are predictable. So one stupid thing, I slow down the movement, except when I want to express the torque. In normally cases, I slow down always the movement at 30%. This is something that I learned from Jonathan Nicotzidis and Matt Moshire 12 years ago. Okay, one of the first rules to increase the predictability, except when you want to express a high level of forces, is slow down a little the movements. And so what does it mean? That probably my cases last a little more in relation to what the software calculated. But today, a lot of time, you send a full class to crowd, blah, 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 and you receive a setup with 24 align, 6 months of treatment. Okay. I don't know if the company want to reduce the number of aligner because it will be cheaper to print the liner for them, or I don't know. But that happens a lot of time within business park, that you have something and the biology is always the same. To fix a class two, more or less, you need between 1 year and 1.5 years align level and do everything. So how is possible to fix in 16 aligner, 20 aligner? Okay, so usually I slow down the movements and allow me, for example, to reduce the amount of appointment and see the patient less frequently.
Yeah, great. I'm going to summarize that because I think I'm going to. There's so much gold in here. So, the first thing is we're going to look at the types of cases. So, relative movements, as you mentioned, for vertical changes, obviously more favorable. Tipping when it comes to posterior changes. Class two correction, looking at compensated cases where it's ideal. But to get true translation beyond the thresholds, as you described, 2.5 millimeters, I think Vincenzo Danto's Delphi study described the same thing from the international experts. Beyond that, you're really looking at skeletal anchorage for them. In terms of other ways to manage the cases, slowing down to make predictable movements, it goes in the face of sometimes the light packages or the reduced aligners. But as orthodontists, we have to respect that tooth movement does take time, and not trying to get around that. I love the fact that you've made that very clear and apparent, that actually we've got to look at predictability, not the number of aligners, not the number of aligners. I'm going to change the direction of conversation and now look at your experiences as an educator. So we've looked at the clinical side. The first question I'm going to ask you, having taught your courses over a number of years and the number of delegates that you've had from Italy and also from surrounding areas and internationally who travel, what seems to be, and this might be too difficult to answer in one go, but what are the most common mistakes that you see orthodontists making when it comes to aligners and their clinical practice with them?
Okay, I think that's because I continue to teach MBT at the same time. Okay, MBT represent probably the 10% of my lecture courses, 90% is aligner. I see the two common mistakes are, first of all, most of the colleagues that do my courses are young orthodontists. So I mean less than 30 years old. So people that have no experience with straight wire. And I continue to believe that if you want to know how to move the teeth with a liner, you need to know how to move the teeth with the braces, because you need to know the mechanics. Because when we use straight wire and no aligner, we study a lot the mechanics. So I apply the force, I do this one and this one, the couple of forces, blah, blah, blah. Then we jump off the liner and they say, okay, write down, please rotate you using the hinge rotation, maybe to the cut designer, and they design for you. Okay, but if you don't know how to do, so which is the mechanics that you have to use, it will be a strong risk. So my suggestion always to new students, something like that, is, okay, you are here for the liner, but you need to know how to move the teeth with a straight wire. Otherwise, it makes no sense. And that's the biggest business problem now, because people and new orthodontists want to learn immediately the line. And the second problem, and that's and I'm really sad, honestly, about that. Okay, you have to know that I do a service on consultation, so you can book 1 hour with me by Zoom, and I help you to design your cases. And every time we discuss about the cases with colleagues that plan and book the hour with me, I always ask to them, I always start from the chief complaint. That's important. I always start from the chief complaint of my patient to decide the goal and how to design the smile of the patient. Okay. And most of the cases, when I ask to them, okay, but which are the goal of the patient, which is the chief complaint? I don't know. They say to me to align. Okay, so which is your goal? I don't know. I mean, the problem, if you want to explain, if I have to explain another way, is the diagnosis. A lot of colleague has a lack of diagnosis. So they don't take in consideration where the teeth are in relation to the face. Okay? If we're coming back to 1992 or 93, when Arnett published the paper in which they say for the first time, hey, you have to do the smile line, the exposure and incisor of smiling, all this thing. Usually I say that before that paper, sorry, in straight wire, the goal was only to align the teeth. Then Arnett taught to us how to line the teeth to get the best aesthetic results because the teeth are in the face. Okay, and with a liner was exactly the same. At the beginning, no one of us know how to move the teeth with a liner, and so the goal was only achieve the class one. But today, that the cases are really more predictable if you know how to plan them, we have to know where to plan to have not only a good occlusion, but also the best aesthetic mean result, the improvement of the profile, the enhancement of the smile, blah, blah, blah. A lot of time, the colleague doesn't know nothing about that. Or I have colleagues that say, okay, I have a crowding in one arch, so I do extraction. And what about the other arch? Oh, I don't have crowding, I don't do extraction. And so how we can finish? If you have a class one, you finish, I don't know, if you're extracting the lower than the upper, you finish with a current class two. Make no sense. Okay. Again, the problem is that people want to go and move the teeth with a liner, but they don't have the basics. And that's the biggest problem, I think. Why? Because the company say to us many years ago, don't worry about that. Send to us everything. We give you the simulation, you approve it, and you will go to the end. But we know exactly what happened. We know exactly what happened. And that's the problem for me. Again, I'm not a scientific man. I read a lot of paper. I'm not a scientific man. But when I see the value, the number related to the predictability of a liner of movements, like, for example, rotation, they say that 50%, 40%, 35%. Okay, but how and who planned that rotation? Because it depends if you, for example, I always create space before doing any rotation around the tooth. Mesial and distal, I always want to create space. Then I put the right attachment. Then I do the rotation only intruding the tooth because I know that you cannot derotate it and extrude the tooth at the same time. And so the problem and in the research, I think that is related to the fact that no one know who planned that rotation. In most of the cases, the rotation are planned by a CAD designer that don't know nothing about mechanics. Okay, I see a lot of time. They say, I see cases distalization. They say, Enzo, I use a protocol. Your distalization works perfectly, and I lose the fitting after 6 alignment. And then you say, and I say to them, okay, click on the second molar. Okay, you pretend to distalize at the same time to extrude 1 millimeter. You lose the tracking to aligner, free aligner, because every bodily movement and every rotation needs at least zero vertical movement, at least. And if you can intrude a little, you can go behind the two that want to escape from the liner. So that's the problem. That's the problem. The people try, and also that they think that the rule copy and paste of Windows or Macintosh works also with a liner. And it's not the truth. Honestly, it's not the truth.
Wow. That's great, and I think that's really insightful. That the solution to planning aligners is to understand fixed appliances. I think that's really insightful. And diagnosis, we can't escape the base principles. And I think you've discussed today not only the principles in terms of diagnostics and case assessment, but also first principles of orthodontics. Force levels aren't negated by changing to plastic. A question, slightly more controversial here. In terms of the drive now of aligner companies towards AI. So to use AI no longer just for segmentation, but actually to derive aspects of the clinical outcome. So exchanging now the CAD designers for AI. The intent here is to try and be as efficient as possible, get your setups back within an hour, get your setups back really quickly. Where do you stand in terms of this idea of having a high drive of number of patients, i.e., the aligner business model, being as efficient as you can to have the least number of aligners? I feel like I know where you're going, but just to ask the question in completion. And can you get high quantity and also get high quality? So, first of all, where, in terms of the direction of travel for AI engaging in the design aspect, what do you think? Second, about high volume and what are the outcomes looking like?
Okay, regarding the involvement of the artificial intelligence in the orthodontics, that's a fact. So we had it. And in 90% of the work, the jobs are in the world, the artificial intelligence is already entered and change the way in which people works. So we have to adapt ourselves. I'm not scared about the artificial intelligence. I don't think that it will be there will be a moment in which they don't need me anymore. They don't need means the company need me as an orthodontist anymore. Okay, and we can take advantage of the artificial intelligence, because if the artificial intelligence allow me to um, spend less time in design my setup, I can do other cases or other things. Okay, we know that's the most important thing in the life of every one of us is the time. I have no time to do all my cases at the setup, and I would like to have more time to spend with my kids. So if I have the artificial intelligence that do a good job for me, I'm not worried about that, because you will have more time and you can decide then to treat more patient or spend your time for increase the quality of your life. So I'm not worried about the artificial intelligence. um, and regarding the high volume and high results, I treat between 300 and 350 cases per year. I don't know if it's a big number or not, because there are, in the States there are who treat 1,000 per year, but they are different countries, so they are totally different. But in Italy, is a huge amount. But I honestly, I know that I give the high quality of results to my patients, so I'm not worried about me. I'm worried about what happened outside my office and the office of who know how to move the teeth. Okay, for example, what I discover or what I realized, there was a moment. Okay, my office. We describe our office as the office of the second opinion, usually, because in Italy it's not normal to have an orthodontic office. There is a dental office, and usually orthodontists work as a consultant. I have an orthodontic office. In Tradate, you say that is a little town, but they have patients all around Italy. Okay, and usually their dentist, there is a moment in which they say, "Okay, it's your time to put an appliance because it's your turn." And they give the price, blah blah, and then they discover there is someone that move only the teeth, so our orthodontic office, and so usually they come for the second opinion. In most of the cases that they start to do the cases with us. But my office is also, sorry, the office of the second opinion, but it's the office also of the second treatment. I have a lot, unfortunately, and I'm really sad about that. A lot of people that just finish a case with a liner on the opposite street, or I don't know, another city close to Trodate, they are not satisfied about the results, and they come to my office to say, I want to retreat it again. And what I discover, and that's what my approach today, is that if I have to retreat you, I don't use a liner, I use braces. And I decide to do something like that for two reasons. First of all, if the previous orthodontist doesn't know how to move the teeth, imagine extra teeth cases. They do, and then they lose so much torque and make the bite deep and deep, and the root cause effect. There is no way with a liner to fix. Okay, so sometimes the previous colleagues lose so much the control that for me make no sense to continue with a liner. But the second thing is the cooperation. Because sometimes the patient that arrive here, they say, the previous orthodontist was not able to align my teeth. Is a patient that wear the liner only during the night, or maybe 16 hours per day. Okay, and so what we know is that with the braces, we have at least is a fixed appliance. So the amount of cooperation is related to the fact that it's fixed. Okay, and so today a lot of retreatment that they do, and we do a lot, are with the braces and not with the liner. Okay, that's the idea that I have.
That's great. Some blue sky thinking here. So, what I would like to know is somebody who's seen the problems, manages them both clinically and in terms of education. What innovations would you like to see? Like, what's on your wish list for aligners to develop into or to have in terms of their innovation?
Okay. Okay, even if I probably the one in the world that use more attachment in any one of my patients, I would like to reduce the number of attachment. But to reduce the number of attachment, we have to increase the thickness of the plastic only in the portion in which you need. So the innovation that probably will change everything for me is when we are able really to print directly the liner. But no, because I want to print in my office. I don't want to print in my office. I have no time. Okay. I wanted the company print for me, but don't print the model and then thermovacuum the liner. I wanted the print a liner with a three-dimensional printer because that's the way in which we can modify the thickness and the trimline for every single tooth in relation to what you want to express. That's the biggest innovation that we will have for sure. But again, it's not for because I want to reduce the cost or do home aligners. Not that idea. I don't have time. Okay, but to have something that is more precise in impressing in transmitting the forces. And the second innovation in which I believe a lot, and this is something that I heard from Philippe, that is the CEO of the dental monitoring, and this is the idea that I really love. He say, imagine a moment in which you design a setup, 40 aligners. The company give you only the first step. The patient start to wear a liner and scan with the dental monitoring every week. Sorry. At the end of the aligner number 9 or 10, you will see the situation. No, you, the artificial intelligence, see the situation. If the fitting is 100%, so the predictor is perfect, you don't know nothing, but you receive next 10 aligner. If there is a misfitting, automatically the artificial intelligence recalculates the misfitting and how to go with how to develop the new treatment plan, taking into consideration my philosophy, my mechanics. It allowed me to receive the new aligner from 11 to 20, but they fit 100%. Okay, that would be amazing, because in that case, every single loosening or fitting, you will recover in 8, 10 aligners. And so he will increase all the predictability, reduce more the amount of refinement, and will be a big advantage for everyone. Us, that we have to work less, and for the patient that can gain a better smile or a good result in few time. That's really important. So he will become more efficient for sure. That's what my dream. But I know that someone is working on that.
Excellent. Well, I'm looking forward to seeing that. That's really cool, and hopefully there are some movements within that side in terms of our technology. And so, the tradition here on the podcast is the final question to be an open-ended one, and that is, Enzo, what one piece of advice would you give to the orthodontists who are listening to this podcast?
Honestly, I have to repeat what I explained you before. So my message have to be: don't believe that it's possible to move the teeth with a liner if you don't know the mechanics, the general mechanics, and the mechanics that's required. And so my biggest suggestion is learn how to move the teeth before with the braces, especially because there is a lot of retreatment that require for sure metal, so braces. Otherwise, you are not able to achieve the results. Okay, and that's the thing in which I in which I want to underline to the colleagues. And don't believe that what you see on the screen represent the reality. That's something that I learned from Barry Glazer 12 years ago, something like that. That's the most difficult switch that you have to do in your head, because at the beginning you see something, oh, amazing, arrived there, okay, click approve, blah blah, and then nothing happened, or you lose the control, and usually what you say, as fault of the patient. The patient is not cooperating. Then, because I do a lot of consultation, I see what the colleagues design a lot of time is your fault, that you approve at the first review. You know that the 80% of the setup are approved at the first review. If you approve a case at the first review, it means that the secretary, your secretary, or your son is approving. Hey, I have, for example, Lorenzo, approve the case of Giovanni. So, because we are orthodontists, and one of the feature of every orthodontist is that our ego is here in relation to all the other dentists. It's true. I have a very big ego. And so if you have an ego, at least you have to do a modification, maybe an attachment. And when I was at the beginning of my experience with aligners, and I didn't understand nothing, when I received the simulation, usually I change 2 or 3 attachments, only to say,
Yeah.
hey, if I achieve the result, yes, it's me, okay. And so please work on the setup, because this is what switch in our job, okay. uh, and uh, and that's a suggestion that's important. I don't know in the other countries, but uh, I had the risk of divorce, let's say like this, two times, oh come on, different times, when I start to bring my cases at home. So before the introduction of liner, usually when you close the light in the office, it's done. You have nothing to do. Okay. Then we start to use the phone for the email, and this is something that usually our wives are not so happy. But there was a moment I remember when I started to use a liner in which clinically I worked all the day clinically on patients, straight wire, RPA, blah 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 blah, and I didn't have time for designing a liner, and I do at home, in the bathroom, in the bedroom, on the flights, make no sense. So a big suggestion is his job is a work. It's required concentration and time. So today, every single day, I have 2 hours in my agenda, one in the morning, one in the afternoon, only to design cases. Then, if I have cases, I will design. Otherwise, I will train the staff. There is always something to do. So, okay, but don't bring your cases at all. It would be a disaster. And so it's something that I know for sure, at least in my country, a lot of people do.
Yeah, that's really sage advice. Enzo, thank you so much for joining me on Orthodontics Interview Podcast. Thank you so much, my friend.
Thank you. It was a pleasure. Really, really a pleasure. See you. Bye bye.